Hello, this is Dr. Bhomik, and I'm here to finish the second part of my lecture, the late effect of childhood cancer therapy on endocrine dysfunction or neuroendocrine dysfunction. In my first lecture, I did talk to you about mostly the growth hormone deficiency and the radiation exposure to the gland. Higher the exposure, more likely to develop the hormone deficiency and also sooner. So in the second part, we'll be discussing about other hormone deficiency, which is not as common but not rare either, is thyroid, precocious puberty, and other neuroendocrine dysfunction. And let's go start with our first slide. And this is the second part, as I have mentioned. And here we are going to discuss mostly about the rest of the neuroendocrine dysfunction that occurs with precocious puberty. Although the other neuroendocrine dysfunction like growth hormone and precocious puberty is most common, but one must not forget about the deficiency of other glycoprotein hormone like FSH, LH, and TSH. These are relatively rare on the radiation dose of 35,000 rats, less than 35,000 rats, and ACTH deficiency can also occur if the patient has received more than 4,500 rats in the hypothalamic pituitary area as well as in the end organ gland region like in thyroid or so. Higher the dose, 4,500 rats, the disruption of hypothalamic inhibitory hormone system occurs, and so there could be hyperprolactinemia. As you know, the prolactin is strictly controlled by a hormone called dopamine, which is the inhibitory hormone, comes from hypothalamus. So measurement of this prolactin is very helpful because if prolactin level is high, that means there is a significant amount of the radiation received by the neuroendocrine system. So possibility of developing ACTH, TSH, FSH, LH deficiency is high, pretty high. The most important one is thyroid dysfunction, and it usually occurs following the radiation of the head and the neck area. Thyroid dysfunction can happen as a primary hypothyroidism, where it is because of the deficiency of controlling hormone, and most of the time it is hypothyroidism. However, sometimes you will see the Graves' disease, and that is most likely because of the alteration of the immune function of a thyroid gland, and therefore producing more a thyroid stimulating immunoglobulin that we see in Graves' disease. Although not as common, hypothyroidism, primary hypothyroidism is more common, where it is manifested by high TSH and low free T4, but the hyperthyroidism secondary to autoimmune disruption can also occur. And obviously people are also very worried were known about the entity of thyroid neoplasm. So primary hypothyroidism, it can occur, and the dose does not have to be that high, 1000 rats or centigrade. So one of the things one need to remember about the hypothyroidism is that it may occur many years after the radiation therapy. And so people probably have forgotten already, and the patient is in remission, and suddenly the patient do present with the symptoms of hypothyroidism. So that the fact has to be kept in the back of our mind. And usually 4,000 rats to the thyroid gland, which is pretty considered as pretty high, and this is actually associated with about 90% of hypothyroidism. And I have a slide to show you later, the graph. And if it is between 2,000 to 2,500 rats, then it's about 50 to 75%. And nothing is solid really written, but these are the presumption and the ranges that we put it here, that I put it here. I've taken from the different studies, and so this should be considered is pretty a good range. Now, if somebody has received both combination of radiation and chemotherapy, then obviously the imaging is going to be high. And this slide shows that depending upon the hair, the patient received on radiation therapy and the radiation and chemotherapy. And as you can see here, that obviously the patient who developed the radiation therapy is from here there is a flattening of the line, but those who have received combination therapy, that tend to be much higher. Now, although thyroid dysfunction, we talked about hypo and hyperthyroidism, but if you ask the physician what they are more worried about, they will say that thyroid neoplasm. Because hypo and hyperthyroidism is easy to treat, but thyroid neoplasm is the one is concerning. However, one does not have to be that concerned because it is mostly a benign neoplasm like follicular adenoma. However, it could be the malignant neoplasm, and which can almost occur from 50 times after the radiation in the neck area. The risk of developing this tumor or malignancy is more common in somewhat age-related also. Younger the age, the greater is the risk of developing malignant neoplasm secondary to radiation therapy. However, one needs to know and feel a little bit comfortable that most malignancies that occurs following the head and neck area radiation is usually the oil differentiated malignancy and carries a very excellent prognosis like non-radiation induced thyroid cancer. So therefore, thyroid, to summarize that, the thyroid could be a little adenoma, follicular cyst, Even it may also present with differentiated malignancies and also localized nodule. And treatment of hypothyroidism is no different than any other condition, uh, but one of the fact one need to remember about that, the goal is to keep the TSH level suppressed, actually a little bit maybe lower than the reference range without making the patient hyperthyroid. So goal is to get the TSH as low as possible, keeping the free T4 in the upper limit of the normal. So once the patient has received the radiation in the neck area, head and the neck area, especially the neck radiation, the patient should be followed at least annually by examination of the neck, palpation of thyroid gland to feel any nodule, to see any changes of the thyroid size, and a measurement of yearly T4. Free T4 is preferably better than free T4, and TSH is necessary, and most of the clinic will do it yearly, and then some of them, if they have received the higher dose of radiation in that local area, they have done thyroid function test every 6 months or so. And however, if once it is decided the patient has developed hypothyroid and you put them on thyroid hormone replacement, again the follow-up should be every 6 months. Our goal again, as I said, to keep the TSH suppressed without making the patient hyperthyroid. So let's talk now about the other important area is gonadal dysfunction. Testicular damage and germ cell damage are germ cells, and testicular damage is very common and vulnerable to both chemotherapy as well as radiation therapy. Decrease or absent sperm count following a testicular radiation as low as 50 centigrade is real. It happened, but if somebody has used the alkylating agent and nitrogen master compound, and then the percentage goes high, and that also depends upon the dose that has been used. And there are certain graphs available that how the incident will go up following this agent use and the dose that they have used, but I thought that was a little bit redundant here. But there are a lot of data are available in this area and available for your further to increase your knowledge further.